Hello everyone, it's Dr. Locklear here, and we are continuing our studies on acid-base balance, and now we are down to the fourth category, which is respiratory alkalosis. This is Exemplar 1D, and it starts on page 27 in your text, so let's get started. So we're going to describe the pathophysiology of respiratory alkalosis. So how does it occur? What are the causes? What are the risk factors and how can we prevent it? What are the clinical manifestations that we will assess in our clients? What are the diagnostic tests and therapies that the interprofessional team uses to collaborate care? Because it's not just nursing, respiratory therapy, dietitian, pharmacist, healthcare provider, discharge planner, all of that. Differentiate care with patients with respiratory alkalosis across the lifespan. So what do we see in children and young adults and adults? The nursing process for culturally competent care to meet for an individual with respiratory alkalosis. So how do we assess and observe and intervene and follow up and evaluate? So our overview. Respiratory alkalosis is characterized by a pH greater than 7.45 and a PaCO2 of less than 35. So now the pH is going up and the CO2 is going down. It is always caused by hyperventilation, so you are breathing too fast. Usually fast respirations or over breathing leading to carbon dioxide deficit. So in respiratory acidosis, you have carbon dioxide overload, and in respiratory alkalosis, you have a carbon dioxide deficit. Our pathophysiology and etiology. In acute respiratory alkalosis, the pH rises rapidly as the PaCO2 falls. Because the kidneys are unable to adapt rapidly to the change in pH, the bicarbonate level remains within normal limits. So at this point, it's happened so fast, the kidneys does not realize that they need to compensate with the bicarb. So the etiology. Anxiety-based hyperventilation is the most common cause of acute respiratory alkalosis. Other physiologic causes of hyperventilation include a high fever, hypoxia, gram-negative bacteremia, thyrotoxicosis, excessive amounts of thyroid hormones, early salicylate intoxication or aspirin overdose, encephalitis, and high progesterone levels in pregnancy directly stimulate the respiratory center, potentially leading to hyperventilation and respiratory alkalosis. Hyperventilation also can occur during anesthesia and mechanical ventilation if the rate and tidal volume or depth of ventilation are excessive. If hyperventilation continues, the kidneys compensate by eliminating bicarb to restore the ratio of bicarbonate to carbonic acid. The bicarbonate level is lower than normal in chronic respiratory alkalosis, and the pH may be close to the normal range. That's chronic. Alkalosis also increases binding of extracellular calcium to albumin, reducing ionized calcium levels. As a result, neuromuscular excitability increases and manifestations similar to hypocalcemia develop. And we know we need calcium for muscle function. Low carbon dioxide levels in the blood cause vasoconstriction of cerebral vessels, increasing the neurologic manifestations of the disorder. So the risk factors. Anxiety with hyperventilation is the most common cause of respiratory alkalosis. Therefore, anxiety disorders increase the risk for this acid-base imbalance. In the patient who is critically ill, mechanical ventilation is a risk factor for respiratory alkalosis if breaths per minute or peak pressures are set too high for the patient's needs. So the respiratory therapist will monitor those peak pressures on the ventilator settings. Clinical manifestations. The manifestations of respiratory alkalosis include lightheadedness, a feeling of panic and difficulty concentrating, circumoral or distal extremity paresthesias, numbness or tingling, tremors, and positive Vostek sign, a type of facial spasm usually indicative of hypocalcemia, and Trousseau sign, a spasm of the hand and forearm. The patient also may experience tinnitus or tinnitus, which is ringing in the ears, a sensation of chest tightness, and palpitations or cardiac dysrhythmias. Seizures and loss of consciousness may occur. ABGs generally show a pH greater than 7.45, a PaCO2 of less than 35. In chronic hyperventilation, there is a compensatory decrease in serum bicarbonate to less than 24 milliequivalents per liter, and the pH may be near to normal because it's trying to compensate. Collaboration. Management of respiratory alkalosis focuses on correcting the imbalance and treating the underlying cause. It is important to create a calm, quiet, low stimulation environment to reduce the patient's anxiety or panic. ABGs must be ordered prior to administration of medication or oxygen therapy. Pharmacologic therapy. A sedative or anti-anxiety agent may be necessary to relieve anxiety and restore a normal breathing pattern. Additional drugs may be ordered to correct underlying problems other than anxiety-induced hyperventilation. Respiratory therapy. Use of paper bags has historically been a recommended treatment for hyperventilation. While use of paper bags helps to raise carbon dioxide levels in patients with true hyperventilation syndrome, it can also cause hypoxia. Other diseases can mimic hyperventilation, such as myocardial infarction, pneumothorax, and pulmonary embolism, or PE. A rebreathing into a paper bag is not always recommended. Elevated carbon dioxide levels have been found to trigger panic attacks, which can further exacerbate hyperventilation. The best treatment for suspected hyperventilation is to teach breathing exercises, encourage the patient to take slow, regular breaths, and breathe into cupped hands. Stress reduction should be strongly encouraged. And you have the clinical manifestations on page 28. So the etiology of hyperventilation: brainstem injury, elevated body temperature or fever, extreme anxiety, hypoxia, increased basal metabolic rate, overventilation with a mechanical ventilator, and salicylate overdose. The clinical manifestations: dizziness, numbness, and tingling around the mouth, hands, and feet, palpitation, dyspnea, chest tightness, anxiety, panic, tremors, tetany, seizures, or loss of consciousness. Clinical therapies: monitor the vital signs, level of consciousness, and ABGs for abnormal findings. Encourage patient to breathe more slowly. Teach breathing and stress reduction techniques. Try to get them to calm down. Administer a sedative or an anti-anxiety agent as ordered. Monitor ventilator settings. And we're very anxious on the ventilator because you got something down your throat helping you breathe, and you just feel like you're suffocating. Administer oxygen as ordered and maintain fluid status. Lifespan considerations. In respiratory alkalosis, there is a decrease in PaCO2 with a deficit of carbonic acid owing to a marked increase in the rate of respirations. This disorder can be seen in children with hypoxia, sepsis, gram-negative organism, pneumonia, meningitis, brain trauma, lesions, and salicylate poisoning. Symptoms and treatment are similar to those seen in adults. Paresthesias can be particularly troublesome for children and parents. Infants may be comforted by swaddling, calming touch, and or speaking with a quiet voice. Toddlers and preschoolers may benefit from holding a stuffed animal, singing familiar songs with a parent or caregiver, and talking quietly about their feelings with a supportive adult. Younger school-age children may be comforted by talking about something they enjoy, such as reading a familiar book aloud with a caregiver, and supportive listening and reassurance that the pain will go away. So children are comforted by someone there with them that gives them a sense of security. For older children and adolescents experiencing paresthesias, inquire about typical coping mechanisms, reassure them the pain will go away, and offer distraction via music or videos on an iPad or other electronic devices. And if these measures don't work, and the situation continues, we need to seek medical help. Okay. Many older adults can maintain acid-base balance under normal conditions. Respiratory distress and chest pain are commonly seen in older adults with respiratory alkalosis. Increased PaCO2 levels or excretion from hyperventilation, so we're getting rid of it, occurs with compensatory response of the bicarbonate excretion of the kidneys. Hyperventilation in older adults may originate from hypoxia, pulmonary emboli, or anxiety. So we need to make sure that we're monitoring urinary output as well. Inpatient care is usually not required with hyperventilation related to an anxiety disorder. Pharmacotherapy is often helpful, but should be used with caution in older adults who take multiple medications because of the adverse reactions between medicines. You got to make sure that they're compatible. Regardless, it is important to rule out any serious problems such as encephalitis, septicemia, before discharging older adults. Outcome depends on the nature of the illness and early diagnosis and treatment. Early is the key, catching it early. Nursing process. Nursing care is focused on reducing anxiety through manipulation of the environment to reduce the stimuli and to create a sense of peace and calm and still, quiet environment. This restful environment will help the patient breathe more slowly and more effectively. Observation and patient interview. Observe the patient for signs of anxiety. Discuss the triggering event for the onset of hyperventilation. Ask the patient about mental health disorders, coping mechanisms, and available support systems. Physical exam. Assess the breath sounds. How do they sound? Are they diminished? Are they clear? Are they rapid? Shallow? Um, Neurologic function, do a neuro check often. Respiratory and cardiac status, tachycardia, tachypnea, which is rapid respiration, and any changes in level of consciousness. Ineffective breathing pattern, anxiety, and risk for injury would be some of the possible priority diagnoses. Planning. Planning for the patient with respiratory alkalosis involves identification and treatment of its underlying cause and the restoration of acid-base balance. Appropriate outcomes include resolution of the underlying cause and that the patient will manifest normal respiratory rate and rhythm, maintain safety, and maintain appropriate fluid status. Implementation. It is important not only to address the hyperventilation, but also to identify the underlying cause. The usual cause of hyperventilation and respiratory alkalosis is psychological, although physiologic disorders also can lead to hyperventilation as well. So we want to assess the respiratory rate, the depth and the ease, monitor vital signs including the temperature and skin color, because we know if we're not breathing right, our skin color is going to change because of lack of perfusion and oxygenation. Assessment data can help identify the underlying cause, such as a fever or hypoxia. Obtain subjective assessment data, such as the circumstances leading up to the current situation, current health and recent illnesses or medication use, and current manifestations. Subjective data provide clues to the cause and circumstances of the hyperventilation response. Reassure the patient that the symptoms do not indicate a heart attack and will resolve when breathing returns to normal. Manifestations of hyperventilation and respiratory alkalosis, such as dyspnea, shortness of breath, chest tightness or pain, and palpitations, can mimic those of a heart attack. Instruct the patient to maintain eye contact and breathe with you to slow the respiratory rate. These measures help make the patient aware of respirations and provide a sense of support and control. Be aware that some patients are uncomfortable making eye contact because of their cultural beliefs. But keep talking to them anyway. Let them know you're there, that you're not going to leave their side. Try to talk them down and relax them. Protect the patient from injury if hyperventilation continues to the point where the patient loses consciousness. The respiratory rate will return to normal, as will acid-base balance. Refer for counseling a patient who has experienced repeated episodes of hyperventilation or who has a chronic anxiety disorder. Counseling can help the patient develop alternative strategies for dealing with anxiety. Planning and teaching for home care is directed toward the underlying cause of hyperventilation. If anxiety precipitated the episode, then discuss the anxiety and stress and what's causing that, and discuss stress management strategies. Teach the patient how to identify hyperventilation reactions and provide self-care, and to avoid those situations that are causing anxiety, and most important, when to seek medical intervention. Because if you can't stop it, eventually you're going to go into respiratory arrest and you need medical attention at that point. Evaluation. The evaluation of care is based on the patient's ability to meet goals set during the planning stage and the outcomes achieved. Nursing care is reformulated as needed if outcomes are not met. Expected outcomes for the patient with respiratory alkalosis include the following. Patient experiences no subsequent episodes of hyperventilation. Patient describes strategies for coping with the anxiety in the future. Family displays ability to contribute to calming patient during times of anxiety, and the patient can discuss with you the ability to calm themselves. Patient and their family participate in support groups that will help the patient cope with an anxiety disorder. Thank you.